Hey guys, welcome back. I'm Dr. Sarah, and this is Dr. Alicia, and this is our third video in our series of labor and delivery talks. So Alicia and I are both family doctors that do maternity care here in Victoria, British Columbia, and we're putting together a series of videos that can help you learn about how to manage labor and delivery. Give this video a like if you enjoy what you've seen here, and subscribe below. We've got great content coming out regularly. You can also check out our website at shefoundhealth.ca for more great info. Make sure you read the medical disclaimers below in the show notes. All other videos that we're making in this series will be posted in our show notes as well. And if you're interested, we're putting together an online prenatal course as well, so stay tuned for information on that.
Great, so let's dive in. This episode, we are going to talk about active labor. So what is active labor, you might ask? Well, it's when you're having regular, strong, painful contractions that are changing your cervix. So oftentimes these contractions will happen every 3 to 5 minutes. They'll last for about a minute, and they'll be happening for more than an hour. And they're painful enough that you're feeling them. This isn't like, this is painful. You got to stop. You got to breathe through. You can't talk to anybody during these contractions. And then in terms of the definition, we call 3 to 4 centimeters dilated of when you're transitioning from that early labor or prodromal labor into the active labor stage.
So at this point, once you've started into active labor, we can predict a bit better how the average woman will progress at this point. Early labor, we can't so much. That comes and goes, and it's different for everyone. So, like Alicia said, we generally say that for a woman who has not dilated her cervix before, we define active labor as when they hit that sort of 3 to 4 centimeter mark. And after that, we can estimate that a woman is going to dilate about 1 centimeter per hour or so, from 4 centimeters to fully dilated, which is 10 centimeters. And we know this will take about, on average, 6 to 10 hours. Some women dilate more quickly and others more slowly. It depends on your pelvic shape, the strength of your contractions, and the baby's position. So again, this is an average, right? So take that information with a grain of salt.
So we often get a lot of questions about what kind of pain management should I use in labor? And to be totally honest, you can't predict how you're going to cope with labor and what it's going to feel like to you. And frankly, from one day to the next, it could feel very different depending on what your mood is, how stressed you are. And so we can have a discussion around what options there are for pain management for you in labor, if you choose any at all. But go in open-minded and don't have a very specific plan of what you want, because you might be surprised. So there's a few different options. We have non-medical and medical. So our natural pain management options can include things like using the exercise ball, walking around, being in a warm shower or bath, but we don't want you in a bath if you've broken your waters. Another options include hypnobirthing, and you can certainly take some courses online, and a TENS machine. TENS machine is a transcutaneous electrical nerve stimulation unit. So essentially, it's electrical pulses stimulating your nerve, which can help with pain relief.
So those are most of our sort of natural and non-medical pain management options. And then we have a whole host of medication options that are available to you. The first one women typically start with is called nitrous oxide. You may also hear this referred to as Entonox or laughing gas. So what it is it's an inhalation anesthetic which can take the edge off during your contractions. Your nurse will give it to you when you feel like it's something you want to try, and you either have a piece that goes over your nose and mouth, or just a mouth breathing piece. You use it during contractions. So you start to breathe in at the start of a contraction and breathe and use it until your contractions subside. This can work really well for a lot of women. And some women, they find it exceptionally helpful if they've been coping quite well without any pain medication through that transition phase. So that's sort of when you're almost fully dilated from 8 to 10 centimeters, which can be really intense for women.
The next group of medications we talk about has 2 separate medications in it, and it's our opioid class of medications. So the medications are 1, morphine, and 2, fentanyl. Morphine is a medication that we would give you a shot in your bum, with some gravel because it can make you a little bit nauseous. And this can last for up to 4 hours, sometimes up to 6 hours in certain women. We use this to take the edge off the contractions and to help you relax a little bit more during the in between contractions. We want to be careful about the timing of this. So if we think you're going to deliver your baby within the next 4 hours, we would try to avoid this medication just because it can cause some decreased respirations in your baby, which are easily managed through stimulation and a medication that we can give your baby if we need to. So if you're getting closer to your delivery time, we would choose the second option, which is fentanyl. This is given through the intravenous, and it's a little bit of a quicker onset and lasts for about 45 minutes or so. So it's great for that last little bit of labor if you need something a little bit more than the nitrous oxide.
So after opioids, next comes epidural. I am an epidural girl. I will just let you guys know I had to have one with each of my deliveries, and they were amazing. So what an epidural is, it's when an anesthesiologist, which is basically a pain medicine specialist, they're called in, and they place by needle and then catheter a tube that goes into your spinal column, and they introduce through there medications that causes freezing and numbness, and it basically affects you from sort of the nipple line down. So it's localized anesthetic. It does not pass through to your baby. And what it does is it takes away pain, but it doesn't take away pressure. So a lot of women can still feel the pressure of a contraction, but the intensity in that pain that's associated with each and every contraction is lessened and sometimes gone completely. So technology has changed a lot, and with epidurals, we talk about walking epidurals. And we often say that that's something that is provided, but to be honest, most women are pretty much restricted to bed after an epidural. I would say it's pretty rare that we see people with an epidural up and walking around.
And if people are walking, it's generally just to the bathroom and back. We're not talking walking the wards. The other thing about epidurals is we generally monitor your baby a little bit more closely with an epidural. So oftentimes you'll have monitors on during that epidural period. Epidurals are also great if you have to go to cesarean section because it makes it a little bit more quick to get to that process done. We can just put some more medication in and freeze you up a little bit better for that.
And there's also a few sort of pre-existing medical or pregnancy conditions where we often recommend what we call an early epidural. So perhaps placing an epidural even before the contractions or the fatigue and exhaustion has gotten to a point where you really want one. And those are in cases like twin or, multiple pregnancies. If a woman, is obese and carries a significant amount of extra weight and tissue, that can cause some complications during the delivery. And for women who have other medical complications of pregnancy, like high blood pressure or other underlying conditions like a heart problem. And also sometimes if your labor is progressing really slowly, an epidural can really be helpful. It can give you a chance to rest and really relax that pelvic floor, which oftentimes allows that baby to move down and into a good position.
Oftentimes people ask, when is it too early to get an epidural or when is it too late to get an epidural? So when is it too early is if you're not into that active labor phase. So generally speaking, we suggest not getting it unless we're giving you medication to get your contractions going prior to about 4 centimeters of dilatation. And when is it too late? Well, if we think your baby's going to be out in the next 10 minutes, because it actually takes about 15 minutes for that epidural to kick in. So in people who are actually progressing very quickly who want an epidural, sometimes we don't get it in time. Or if your baby is about to come out, then we often wouldn't get it for you. But I've given epidurals or gotten epidurals for women who've been pushing for an hour already.
Yeah.
So
I'd say it's pretty rare for it to be too late to get an epidural because I think that's a common fear among a lot of women. So don't worry, I had that fear. My birth plan was always contractions, hospital, epidural. Worked for me.
3 times. Great. Well, that's our topic for today. So hopefully you found it interesting. We'll link to all the other videos that we've made in this series below. Don't forget to hit subscribe and check out our website at www.shefoundhealth.ca. Have a great day.
Thanks, guys.